do a few of these. We don't have to go for a full 30 minutes, but we'll do a few of these. So what are you looking at here?
Okay, so punch biopsy, and I see superficial and deep perivascular inflammation.
Good. What kind of cells?
It looked like lymphocytes.
Good. Very good. What's our differential?
Polymorphous light eruption.
Well, that's not a differential.
Well, that's one thing on my differential.
Good. What's the classic ones that we think about automatically when we think of this pattern?
The L's.
Yeah, good. That's what I was trying to get at.
Lupus.
Yeah. Yes, polymorphous light eruption is on there. Lupus is on there. What else is on there?
Leprosy.
Oh yeah.
Sorry, oh, I'm not.
Oh, CLL is
Good.
on there.
Good.
Louis syphilis.
Good. Lyme disease, right? That's on there.
Lyme disease, yep.
Lymphocytic infiltrates are on there. Okay, so and then notice there's no epidermal involvement here. So how are we going to tell these apart? Is there anything here that can help us?
Lupus, mucin.
Yeah, so what's the diagnosis?
Lupus.
Which form of lupus?
Imagine
what this would look like in the patient, right? It's going to look like kind of an urticarial plaque.
So subacute.
Well, subacute's usually going to give you more of a kind of a papulosquamous morphology or an annular morphology with some scale because there's some interface change with that. Remember, this one doesn't have much interface change here. The epidermis is spared.
Okay.
So there's one other form. It is lupus, but which form doesn't give you much epidermal change and looks like this with mucin? Now, discoid gives you the epidermal involvement also, right? The follicular plugging.
Oh, that's right.
So what's this one? You're close.
Like an acute cutaneous lupus?
No, I didn't usually give you superficial deep, but that also gives you interface change with vacuolar alteration.
Oh, that's right. Oh, Tumid.
Drug-induced?
Tumid form. Tumid.
Yeah.
Tumid form, like a swollen, like a tumor, like a plaque that's got no epidermal. So the tumid form, Ellie. Good. This is lupus, so you're right. And you're right about the 5 L's. Okay. What's the pattern here?
Come through. Hey, I can do this. Sorry, we were trying to get the audio figured out. Okay, so looking here, there's a punch biopsy, and let's see. Okay, so it includes epidermis, dermis, and subcutaneous fat. In the dermis, there looks like, well, I can't exactly tell what's going on. It's a lot more red in color, almost like it could be extravasated erythrocytes, maybe, or degenerated.
Yeah, one kind of pearl is if you see a biopsy that's got just looks like a lake of red cells in it, it's probably at the time of the biopsy. Probably it's artifactual.
Oh, okay.
So forget about that.
Okay.
So where's the main pathology, or why am I showing it to you at such a low?
Septal panniculitis. I see some inflammatories.
Okay, it's a panniculitis. Okay, good. And you think it's septal?
Well, yeah. I mean, I see some cells between the fat cells, but mostly septal looks like in between the lobules.
Well, it's definitely septal, but it's also definitely lobular too, right? So it's got a lot of lobular involvement also. So it's septal and lobular, but it's mostly lobular, I would say. It's like mostly lobular. Okay, so what's the next step we ask ourselves when we're looking at panniculitis?
what type of cell it is.
Okay, that's one thing we can ask. What kind of cells are we looking at here?
These look like lymphocytes.
All lymphs?
Oh, then there's some EOs in there too.
Good. Lymphs and EOs. Excellent.
Uh-huh.
What else do we ask ourselves when we're looking at a panniculitis?
Um, uh,
Do you need to call a friend?
if there, well, I was gonna say if there's like necrosis going on, but no.
Oh, you could. That is
It's
something to look at.
close.
I'm sorry, what'd you say there?
That's like, because I mean, I wrote in my notes like vasculitis or no vasculitis, but it's kind of like
Yes.
you're thinking of that.
Vasculitis or no vasculitis? That's one of the next things you ask. Is there vasculitis or no vasculitis? That's important. And then you look at the type of cell. Okay, and is there vasculitis or no vasculitis? You think there's any vasculitis here?
It looks like there is.
If it is, it's just secondary inflammation around the blood vessels. I'm not sure it's really.
Well, I don't know. Oh. Okay.
So mostly lobular, maybe a little bit of septal too, but mostly lobular. No significant necrosis, maybe some fat microcyst here, but no massive necrosis, no vasculitis. So what diseases can we rule out based on that?
Definitely, like erythematosus, you can rule that out.
I agree. Probably very unusual for erythematosus to give you this pattern. They usually give some granulomatous inflammation. We don't see that here. There's no vasculitis. So if it's vasculitis plus lobular, what do we think about? With a lot of necrosis and degeneration of the lobular fat.
Is that like pancreatic? That to it, or
No, that's more degeneration of fat with secondary neutrophilic infiltrate. So not really vasculitis there. But if it had vasculitis and it had lots of lobular involvement with degeneration of the fat in the lobules, what's that diagnosis?
I'm not sure about that.
Okay, anybody know?
Lupus panniculitis?
No, that's nodular vasculitis.
Oh,
Nodular vasculitis, erythema indurata, vasculitis, lobular panniculitis, degenerative fat, suppurative granulomatous inflammation, a lot of times suppuration. That's nodular vasculitis. We don't have that here. We got EOs and
Oh.
lymphs.
so erythema indurata?
That would be vasculitis plus lobular panniculitis. So we don't have that. This is not erythema indurata. It's not erythematosum. It's not erythema indurata or nodular
Not
vasculitis, which are the same basic entity. Those are usually associated with an underlying systemic illness of some sort. Okay. Is this any of the crystalline panniculitides? Subcutaneous fat necrosis of the newborn? One of those conditions. You see crystals?
Oh yeah.
I don't see them. So no.
Oh, those aren't.
It's not Sclerotinia innatorum. So no, there aren't crystals here. This is just some fat degeneration here. So this is an unusual panniculitis. Mainly, I just wanted you to recognize the pattern. It's probably some kind of we call it an eosinophilic lobular panniculitis, which is sort of analogous to Wells syndrome of the fat. You kind of think of that way. Okay, so basically, I'm not sure you'll even be asked that on the boards, but it's just basically showing you the pattern of the panniculitis here and ruling out those other things.
Okay.
Okay. Okay, so this is very big, maybe like an excisional.
Okay, or maybe a, saucerization shape or saucerization, might have been pedunculated.
Yeah, maybe pedunculated. It looks like neoplastic.
Good.
Not quite sure if epithelial or not epithelial at this power.
Okay, could maybe be either one. I don't disagree with that. You like benign or malignant?
It seems well circumscribed and pretty symmetric, so I'm gonna say benign.
Let's turn it this way too for interest.
Yeah,
So
I was
what
gonna turn my head that way.
that, you know, things are a little, looks like a little face almost. It's
Yeah,
kind
it
of,
looks like a skull.
sort of does. Okay, so look at our magnification, see what we sort of favor benign. Let's see if we can tell what kind of differentiation we're dealing with. We're not sure at this power yet. Got a lot of big vascular sort of areas in it. Maybe it's hemorrhage into the lesion.
Mhm.
Let's get on the higher magnification, see if we can kind of tell now what we're looking at here.
Non-epithelial.
Good. Absolutely non-epithelial. Excellent. Any ideas? So we're not epithelial. What are our three main ones we instantly kind of we think about right off the bat?
Like fibrohistiocytic
Good.
or like neural
Neural. Good.
or muscles.
Good. Good. Excellent. So given that those are our three most common ones, do you think it's any one of those three?
Mhm. Well, it doesn't look like a lazy yes, really. I think it's too wide for that. Is it like a cigarette, maybe? The cigar
Maybe.
shape?
Yeah, so if you weren't sure, you might say, well, so you maybe say what if you weren't sure?
Um, what would I
Well,
say? I would say, well, like some parts look like it could be like that cigar shape nuclei for the muscle.
touch of laziness here, though, aren't we? It's not great, but we're seeing a touch of it here. This just shows you
Maybe a
these things
touch.
like the textbook.
You think it could be mixed?
Well, you probably wouldn't be mixed, but there's
Like a
another.
fibrohistiocytic?
Well, I can see how you're struggling with this a little bit. Here's another clue. You get a big, thick PAS positive basal membranes around this blood vessel. Now, I think I told you that before, but it probably didn't register. But that's very classic for neural, if you see that. That's helpful
Okay.
for. Now, let's see if we can look at the edge of this thing too. Often in this specific lesion, you'll kind of see a little residual nerve twig out here, maybe. All right, so I'm going to spot you and tell you this is neural.
Okay. I'll take your
Okay,
word.
so which type of neural then? Once we're neural, benign. We don't have too many of those either.
Right.
So what's the most common benign neural?
Neurofibroma.
Yeah, by far the most common.
Yeah.
Okay, so that's Schwannian. What's the second most common Schwannian tumor?
Schwannoma?
Yes, that's what this is. This is a schwannoma or Neurilemmoma, another name for it. Okay. And these usually tend to be more cellular than a neurofibroma. They'll often have this pink kind of more cytoplasm. You know, these are maybe sort of a little bit S-shaped. Just goes to show you that that's not perfect. You kind of have to look carefully to find some of it here that you can convince yourself are S-shaped. The stroma is more myxoid than neurofibroma. I'm sorry, than leiomyoma. That would go against it. Those blood vessels, the big thick PAs positive, that helps you for neural. Unusual to get hemorrhage like this, massive hemorrhage. That's more common into a schwannoma than it would be a leiomyoma. So this is just an example of a neurilemmoma or schwannoma.
Okay.
Okay, a little harder. Time for maybe a couple. We have two more here. We'll do.
Okay, so we have a shape biopsy.
Okay.
And it looks neoplastic.
Good.
Um,
Can you tell about the biologic behavior?
oh, it, I mean, I think I would go with malignant here.
Yeah, we're compromised, aren't we? Got to shade.
Yeah.
tip of an iceberg. Iceberg. So we don't know. And why'd you go with malignant, just out of curiosity? You're right. But why'd you go with it?
I mean, it's not the perfect, like, well circumscribed or
Good.
uh,
It goes to the bottom, and
yeah.
doesn't go to the side necessarily, but it goes over here to the bottom and maybe to this side. So we can't assess symmetry, circumscription. This is the tip of an iceberg. It can go really, really deep. So we
Yeah.
may be malignancy. Notice also when you look at the individual aggregations, they look different. Small like aggregation here, cords and strands down here. That's kind of a sign of malignancy in some cases. So it's a sign of asymmetry.
Yeah.
It's got a little, what's this little structure?
Is that a pseudocyst?
It's a small cyst. Good.
Oh, it's a small cyst. Okay.
Epithelial or non-epithelial?
I'm leaning towards epithelial.
Good. I like that you're leaning in that direction. You're right. So what's the pattern of this tumor here that we're looking at? Right here.
I mean, it looks like it's like the strands that you were talking about. It's
Yeah, good. There's cords and strands of these cells, and we refer to that as a sclerosing epithelial neoplasm pattern. Okay, we commonly do get shade biopsies of these because clinicians usually send them in as roulette scar. They're often white lesions on somebody's head and neck area, often of a woman. They don't think of a cancer, so they take a shave, and we see the surface of a sclerosing epithelial neoplasm. And then the differential diagnosis there includes three classic things when they're primary in the skin.
hmm.
Ring any bells?
No, but I was thinking this could be like an ecrine.
Okay, well, ecrine is one of the three types. Yeah, that's one of the three types. There's a thing called the syringomatous carcinoma, also known as microcystic adnexal carcinoma, which that's what this is. And one of the ways that you can tell those apart from the other two are these whorls of squamous epithelial structures in here.
Is that like the squamous eddies?
These aren't really squamous eddies.
Okay.
These are like whorls, they're sort of like squamous eddies, but little like small whorled aggregations of squamous kind of metaplasia in you, if you will. These are the main lesion, the cells that you see, these little cords and strands. And see, that one's also got a little squamous differentiation. So when you see that, it favors microcystic adnexal carcinoma. The other two are desmoplastic tricho. You get more cysts, more follicular differentiation, calcification, and then morphiiform basal cell carcinoma. Basaloid aggregations with clefts between the epithelium and the surrounding stroma, which you don't see here so much. So this is microcystic adnexal. And you'll often get these little sort of mini milia-like cyst-like structures in this lesion. You also see those in desmoplastic tricho, not so much in basal cell, but usually if you get those, you'll also see some more basaloid differentiation, follicular differentiation, plus the calcification. So this is MAC this time. These also tend to go into nerves. We don't have any nerves here to look at, but they often get into nerves. Okay, last one.
Okay, so again, we're looking at a shave biopsy, I think, or maybe even excisional. This is like a lot
Good.
of
Excision biopsy. Very good. Excision.
Yeah, so this is a nodular lesion. There's I'm gonna say it looks this is neoplastic.
Good.
It's somewhat circumscribed. I mean, I can kind of make it out, but the borders aren't very well defined. It's not encapsulated.
Yeah, it seems like that's kind of the whole thing. They excised the whole lesion. So it seems like they got it all out. Okay.
It's large, symmetric, at least on low power.
Fairly symmetrical, I agree. It's kind of got even also kind of wedge-shaped vertical orientation. So that favors what?
Benign.
Good, favors benign. And we could be wrong. We go to the next power and see tons of anaplastic cells and change our mind. You think it's epithelial or non-epithelial, you're not sure at this power.
I'm not sure.
Yeah, and it looks a little bit, it doesn't look like a classic epithelial neoplasm, so this could be lymphoid, a number of things we're not sure. So we're gonna go to higher magnification, see if we can get more sure. And now, what do we see?
Oh, so there's some foamy looking cells in small aggregates.
Said foam. What
That's
color
what-
is foam?
Oh, like white,
White. What color is this?
purple and white.
It got almost kind of pinkish purplish, grayish.
Okay.
I don't see so much white. You're seeing small little dots,
Yeah.
right? So what do you call those?
Granules.
Granules. What's the diagnosis?
Astrocytoma.
Well, you said granules. I was hoping you kind of take that to the next level.
Granular.
Granular cell tumor.
Oh, okay.
Granular cell neoplasm. Granular cell tumor. This is a granular cell tumor. What are these granules? Bonus question. Jeopardy. What are the granules?
The heparin,
No.
histamine.
Good idea, because they are granular when they're inside mast cells, but these are not mast cell granules. The granules here are basically lysosomes that have engulfed a breakdown product of Schwannian myelin material. So this is in the neurocrystopathy. This is basically a lesion that's in the neural differentiation. So these are little cells that are trying to make Schwann cells. They never made it there, and they gobbled up these myelin breakdown products that are lysosomal breakdown products with myelin in here. So this is a granular cell tumor. That's what the granules are. This is a neural neoplasm. So if you stain it positively with S100 protein, guess what? It lights up like a Christmas tree. If you stain it with PAS, those granules light up. So granular cell tumor. Now, one
So
thing
it's
these are often-
digested like Schwann cell?
it's
what
in the
is it?
Schwannian, they're not really Schwann cells, but they're basically in the Schwannian family of cells. They're sort of bizarre Schwann cells that went off the rails.
Okay.
Never made really classic myelin that went around the nerves. Just ended up forming these granules here. And you often get pseudocarcinomas hyperplasia overlying these. You get misdiagnosis of squamous cell if you get a shaved biopsy of that. I've had that happen to me once before. So just realize that you need to get a decent biopsy because we get pseudocarcinomas hyperplasia overlying these things. All right, any questions? Okay. See you guys manana.